I'm Greg Simon. I'd like to thank the organizers for the opportunity to describe to you our work collaborating with large health systems to address and reduce suicide risk. As we've heard, the health system agenda regarding prevention of suicide and the health system agenda regarding prevention of firearm violence and death are not identical, but they are largely overlapping. The work I'll describe to you today has been funded by a variety of cooperative agreements and contracts with the National Institute of Mental Health and more recently by the Food and Drug Administration. I'll start by showing a graphic that really caught my attention the first time we saw it. This shows the number of Americans dying after being struck by lightning over the last 75 years. Even though the population of the United States has more than doubled in that time, the number of lightning strike deaths has gone down by about 90%. We might ask, how was that accomplished? Because being struck by lightning is quite literally like being struck by lightning. And we'll come back to that. But to describe to you our mental health research network, we are 13 large integrated healthcare systems and their affiliated or embedded research centers. These health systems serve a combined member patient population of about 14 million Americans, diverse and generally representative of the geographic areas they serve. These are integrated systems in that they provide comprehensive care, medical care, mental health care, as well as insurance coverage to define member populations. They all therefore have longitudinal data from their electronic health records and from insurance claims. And these data have been harmonized into compatible data resources that are held in each of the health systems following the HCSRN or Healthcare Systems Research Network common data model. Probably our most important asset is all of us have very strong partnerships with our delivery system and our health plan leaders in each of these health systems. So our work regarding suicide prevention actually began probably 6 or 8 years ago, really in direct response to a question from our health system partners. At that time, our health systems were engaged in a systematic effort to improve mental health care by using systematic outcome measures. The term measurement-based care or feedback-informed care is very common in our systems these days. And what this shows is a metric we were monitoring at the time, which was when one of our members initiated treatment for depression, was there a score for the PHQ9 depression questionnaire recorded in their electronic health record. You can see there were a couple of our health systems where this practice was well established, a couple that were lifting off, and I would say lifting off at relatively impressive rates during that period. But as this happened, we began to get questions from our frontline providers and from their managers that when someone answers this question, the PHQ9, and specifically they answer that last question about having frequent thoughts of death or self-harm, what does that actually mean regarding their subsequent risk of suicide attempt or suicide death? And our answer was, before now, no one has had the data to answer that question, but now we do, so we should look. And when we did, what we found was, shown on the left-hand graph is risk of suicide attempt, on the right-hand graph is risk of suicide death, that those who reported having thoughts of death or self-harm nearly every day were 8 to 10-fold more likely to either attempt suicide or die by suicide over the year following the visit where they completed that questionnaire. So we brought this back to our health system partners, and what that led to were sort of 3 streams of action. First, a relatively rapid implementation of standard care processes, because having seen this, our health system partners said, there are some things we will not wait for evidence about, and we will decide that we now need to do. We believe this evidence is actionable enough that we need to identify some best practices and implement them. There was also a middle stream of work regarding more aggressive outreach, where our discussions with our healthcare systems led to the conclusion that there are some things we believe might work, but they are not trivial, and we should have better evidence before we decide to do them. And then also a third stream of work that was really in the area of methods development. So I'll describe each of those to you in a little bit of detail. Regarding implementation, what really motivated our healthcare systems was seeing that, if you can see on this table, this is in our mental health specialty clinics, how people responded to that 9th question of the PHQ9, what the proportion of visits in each category were, and what proportion of suicide deaths over the following 90 days occurred. So you can see that 6% of our visits involved a response in the 2 highest categories, and that accounted for about 40% of suicide deaths. So a 40% sensitivity, not great, but good enough to act on, and also you could say about a 6 to 7-fold risk concentration, from 6% of visits accounting for about 40% of events. So with that in mind, We published these findings first using data from Kaiser, Permanente, in Washington in 2013. And even before they were published, we brought these results to our health systems, and our health systems began implementing standard work processes. The standard work process involved, if someone responded at this high level to item 9 of the PHQ, our providers were expected to conduct and record a structured assessment of suicide risk using a common, and at that time, sort of the state-of-the-art instrument, the Columbia Suicide Severity Rating Scale. If someone's risk level on that scale was greater than 3, the provider was expected to create a collaborative safety plan and record that in the record. That planning included routinely assessing access to firearms. All of this was supported by, rolled out a comprehensive provider training program across all of our mental health specialty clinics and tools embedded in the electronic health record. So this is just an image of the questionnaire that people fill out initially at every mental health specialty visit. In our Kaiser region, there are similar questionnaires now in all of the Kaiser regions. You can see circled that 9th question of the PHQ9 about thoughts of death or self-harm, and there at the bottom the question about access to firearms, which is routinely collected at every one of our mental health visits. As this implementation was rolled out, to me one of the most interesting findings, if you look down there at the bottom, you can see that by 2015, we actually were not only monitoring provider performance, but it was part of our performance-based compensation. And when the first performance-based compensation reports rolled out in late 2015, there was a certain Dr. Gregory Simon who did not do very well. Dr. Gregory Simon actually scored at the 83% level, which was actually below the sort of minimal accepted standard. And Dr. Gregory Simon had this program, this was the pilot, had this program been rolled out, would have been docked $233 in his pay in that quarter. So although I am not proud of my personal report card, and I'll tell you it has improved since that time, I am very proud of our health system in terms of a 22-month gap between publication of findings and implementation to the stage where the first author of the publication is going to get his pay docked if he does not improve his performance. What's now happened across Kaiser Permanente and some of our other partner health systems in Henry Ford in Detroit and Health Partners in Minnesota is a sort of more national effort in implementation, which is more systematic and more widespread, following the National Action Alliance for Suicide Prevention's Zero Suicide model, which is a nice sort of framework for hanging a suicide prevention program on. Includes the steps of identifying people at risk, engaging people in ongoing care, providing evidence-based or empirically supported interventions, and attending especially to transitions between sectors of care, transitions from hospital to outpatient, from emergency department to outpatient follow-up. And what we're now undertaking is a large national effort that will involve 6 of our health systems that care for about 9 million members. Each of our systems is choosing from a specific menu of interventions or quality improvement activities that are following this zero suicide model. We're in the midst of right now, and actually fairly far along, in developing very specific metrics to assess both the desired changes in care process as well as the desired outcomes, both intermediate and ultimate outcomes, that we will be monitoring in these 6 health systems as they implement these programs over the next several years. We'll be using these metrics to provide feedback to individual providers, to clinic managers, and to, as scientists, to assess the specific effectiveness of these different improvement programs. And most important, to get these health systems together to make relatively transparent comparisons of their performance compared to each other and compared to themselves over time. Come back to that a little later. So the middle stream of work, the effectiveness work, when we brought this back to our health systems, it was very clear. What they told us was that when we have someone sitting in one of our clinics who has just told us they have frequent thoughts of death or self-harm, we're not asking you right now for randomized trial evidence that we should do something about that. We think that's actionable enough that we feel really a moral imperative to act. But we know that people who are at risk often drift out of care, get disconnected from care. And we were especially interested in the potential benefit of more intensive or aggressive outreach programs to people who become disconnected. Those programs would not be trivial in terms of their cost, and to be honest with you, in terms of their potential intrusiveness, because some people might object to that kind of outreach. So after a lot of discussion, we decided that was an area for experimentation. So what we undertook then was proposing, and it was funded by the NIH Collaboratory Pragmatic Trials Program, a large pragmatic trial in our health system, in 4 of our health systems. Those are 3 regions of Kaiser Permanente and Health Partners. in which patients who filled out a PHQ9 questionnaire and reported frequent thoughts of death or self-harm were randomly assigned either to a usual care control arm or to one of two population-based interventions, both of which involved outreach programs intended to supplement, not replace, their usual care. Programs delivered primarily by online messaging, but also by telephone so that they could be scalable and affordable. One of the programs emphasized training in dialectical behavior therapy skills, one of the empirically supported interventions for people who are at risk for suicide. One of the others was a more traditional care management program aimed at keeping people engaged in mental health care. We've just completed the enrollment of that trial. We've enrolled and randomized about 19,000 people across those 4 health systems. The interventions will continue up until about the middle of next year, so we won't have the findings for that trial available probably until late 2019 or early 2020. And then the third stream of work, although we said we believe that the data we get from these PHQ9 questionnaires are powerful enough predictors to be actionable, they're still really somewhat disappointing. So what we see here, this is the same graph or chart I showed you before, although we do have the ability to achieve, I would say, a 6 to 7-fold risk concentration, we still miss 35% of events of people who report they had thoughts of death or self-harm not at all. 35% of suicide deaths in the following 90 days occur in that group. And even though our systems are doing fairly well at completing PHQ9 questionnaires, they are sometimes still missed. And probably most important of all, patients who do not show up for their visits, we have no questionnaires, and those may be the people about whom we should be most concerned. So we undertook a project then to say, could we use data in the electronic health records to develop accurate prediction models for both suicide attempt and suicide death? That project involves 7 of our mental health research network health systems, serving about 8 million members. The data we used for this was from about 20 million visits by about 4 million members. We developed separate models for people who visited specialty mental health providers and people who visited general medical or primary care providers but had a known mental health condition. We linked those data to data from our records about non-fatal suicide attempts and data from state mortality records about subsequent suicide deaths. I can get into the nerdy details in the question time if you want, but we in the electronic health records, using some methods we'd already developed, we defined about 150 sort of commonsensical clinical predictors from people's past mental health and medical diagnoses, service use patterns, 200 possible interactions among those. Develop models in a 65% randomly selected portion of the sample, validate those models in another 35%. What you see here are, just to demonstrate, these fancy machine learning techniques select the predictors that any reasonable clinician would expect. They're just able to do the math a lot faster than a reasonable clinician could. So what you see there on the left are the model that predicted suicide death following a mental health specialty visit, selected about 62 predictors. Those are the top 15. The model to predict suicide death after a primary care visit selected about 43 predictors. You can see there on the right, those are the top 15. There were very similar predictors selected for non-fatal suicide attempt. These graphs show, to the nerdy among you, receiver operating characteristic curves. One of the important points is, because the sample is quite large, one of the problems with machine learning, which is slippage between the sample in which you developed the model and the sample in which you validated it, really did not occur here. They're actually red and green lines there, but you can't distinguish them because they're on top of each other. The model for predicting suicide death after a mental health specialty visit has an overall accuracy of about 86%. The model for predicting suicide death after primary care visit about 83%. And to put this into more practical terms, you can see on the left the table we looked at before about using the PHQ9 compared to on the right using these calculated risk scores. What we see is we have both a better ability to concentrate risk at the top of the scale. We have in the top 5% of visits account for nearly 50% of events, so we can accomplish about a 10-fold risk concentration in a somewhat smaller group of high-risk people, and also miss fewer events at the bottom. The bottom 75% of people accounting now for under 20% of events. So the cycle starts over. You know, what these findings do is then they initiate another cycle of implementation and effectiveness research and looking for new methods. So what's happening now is that these risk prediction models will be used to augment the previous standard work processes. soon to happen in Kaiser, Permanente, Washington, and not that long after in the Northern California region, we'll be bringing these risk scores into the electronic health record and serving these to providers at the point of care. So the rule will no longer be if item 9 score is greater than 2, then do Columbia. It will be if item 9 score is greater than 2 or calculated risk is above 95th percentile, then do Columbia. We're planning new effectiveness research. One of the very interesting areas over the next 5 years in this area are going to be the new glutamate receptor modulator or ketamine-like drugs, which have been shown to rapidly decrease suicidal ideation. The big public health question will be, will they actually reduce risk of suicide attempt and suicide deaths? So we're already planning large pragmatic trials to address those questions. And then hoping to improve our risk prediction methods. We're now harvesting another round of data to improve those prediction models, add additional predictors, use more detailed encoding of timing. Happy to talk about that with you who have pocket protectors on you during the question time. We're also going to be extending this risk prediction work to develop prediction models for people seen in emergency departments or people discharged from hospital, interested in linking some of our health records data to more location-based data and also to financial data, because we know that those issues are very important in terms of prediction of suicidal behavior. Just a few words about the new implementation work. So what will soon happen is that we will be using these risk scores in addition to, not instead of, people's response to PHQ9 questionnaires to both drive this standard work process during visits, but also more important, what we were not able to do before is to do outreach between visits to people who either cancel a visit, do not show up, or even are overdue for a visit, because we can calculate these risk scores daily on everybody in our member population, even if they're not arriving in one of our clinics at that time. If any of you are interested, all of the technical tools needed to develop these models and validate these models are on a public GitHub repository. We're very interested in putting all of this information out in the public domain for people to see if they would be able to use it in other health systems. We're already in discussions with at least the Epic electronic health record vendor, because they will be rolling out new predictive analytics modules as standard features in the EHR. So this model was built from the beginning to be easily uploadable using the predictive model markup language industry standard that's going to be used to bring these models into electronic health records. So we hope that this will be widely available to other health systems in the very near future. So just a few concluding remarks about what we've learned over the years, not so much in terms of suicide prevention, but in terms of building and operating a network like this and what it takes to make it work. We operate in the world of integrated healthcare systems that are responsible for defined populations. This matters, I think, both in a technical and a cultural sense. By technical, I mean we have comprehensive data because we are responsible for everyone's healthcare. Even if they receive it from another place, we're responsible for paying for it. And also these health systems routinely link our membership data to data on injury and poisoning mortality. And this is something I suspect many healthcare systems do not do. In talking with other people about suicide prevention, and we talk to people about how do you know you're improving, and they say, well, we know about suicide deaths because sometimes people tell us about them. And if we're really interested in systematic improvement, we need to measure and hold ourselves accountable, and there's only one accurate way to measure mortality. That's with state mortality records. The technical issues, having harmonized data resources is really absolutely essential. It makes this work much more efficient. At this point now, when we send out a program to harvest new data to build new prediction models, some of these programs take a long time to run, but a long time means we can get a turnaround in 2 days, not 2 years, in terms of someone having to redo all of the work in terms of bringing the data into the same form in different places. We also very systematically assess the quality of data in our research data warehouses. And it is not always perfect. Data streams break, things go wrong. But as long as we're assessing every quarter what those problems are, we can fix them before we are misled by things that aren't actually true. Probably our most important asset here is the human resources, the very highly skilled analysts who are not only familiar with the technical tools, but also they live close enough to the data generating process to know where the problems are. And building reusable tools so that if we say we're interested in building a new prediction model, we want to re-specify certain predictors, we don't have to start from scratch. And then Finally, and probably most important in terms of the key ingredients, I'd say would be the culture. We always are engaging with health system leaders who I think are committed to systematic improvement and see systematic measurement and accountability as core to their mission. The transparency and trust and the importance of that can't be overestimated. It was not easy to get to the point of health systems saying, we are going to come together and transparently share information about how many people die by suicide and whether we did the right thing by them before they died. But we are at that point now, and that's incredibly valuable in terms of quick learning. And finally, being willing to hold ourselves accountable, which is why I show my report card. But I want to say accountable within a just culture, as I commented yesterday. I think we cannot always hold ourselves accountable to outcomes, but we can hold ourselves accountable to right processes. So back to the lightning strike deaths. We did not eliminate thunderstorms. Actually, if anything, there are more of them now than there used to be. And we did not invent a vaccine for electrocution. What we did was we got better at predicting risk. Despite all the jokes about it, weather forecasting is a lot better now than it was in 1940. They have even fancier math than we do. And we developed really effective public health messages. And so I think taking that example of saying in this area, how do we identify time, places, and situations of high risk? And how do we develop effective messages for people about if you are at risk, you need to avoid dangerous things and go to safe places? And those are fairly simple messages. So like the last panel, I'm hopeful. Thanks.
Thank you very much.